All right. Well, hello, everyone. Good evening. My name is Marcy Rubik. I'm the Executive Director of the Limb Preservation Foundation. We are very pleased to have you with us this evening, and we are very pleased to share a program on osseointegration with Dr. Jason Stoneback and Dr. Danielle Melton of UC Health. We are this evening, this is the agenda for the program. We're going to meet the moderators. I just want to say just a couple words to say thank you to our many generous sponsors. We appreciate you very much, our partners, volunteers, board members, and our staff for their dedication. And at the end of this program, we are going to send you a survey. We would love it if you would complete that survey. Everyone who does that will be entered into a drawing for a $100 Amazon gift card. We will announce the winner's name in our August newsletter. We'd also like to mention that this program is being recorded. So if there is someone that you think could benefit from it, please visit our website and check into the Learning Lab section for more information and to check out this program and many others. So it is my pleasure to introduce you to two nurse practitioners that work with the doctors and the team. Please welcome Maria Kouzmina and Molly Reasner, who are going to introduce the speakers.
Thank you, Marcy. My name is Molly. I'll be introducing the speakers tonight. So Dr. Jason Stoneback is the Chief of Orthopedic Trauma and Fracture Surgery at the University of Colorado Hospital. He is also the director of the Limb Restoration Program and multidisciplinary team, specifically specializing in the treatment of complex and simple fractures, non-unions, malunions, limb length discrepancies, deformity correction, amputation surgery, in addition to being one of the most experienced osseointegration surgeons in the world. So he'll be speaking first, and then I'll introduce Dr. Danielle Melton next. She is a physical medicine and rehabilitation physician who has extensive experience and specialization in the care of people with amputations, encompassing pre-prosthetic management, prosthetic design and prescription, and rehabilitation. She is the director of our amputation medicine and rehabilitation program at the University of Colorado. And I will hand it over to Dr. Stoneback.
All right, thank you very much, all of you. And thanks to the Limb Preservation Foundation for asking us to speak about osseointegration. So a little bit about osseointegration. So why do we do osseointegration? So really, it's really difficult being a socket wearing amputee at times. I'll give you an example by Donna, who is, when she was 31, she was involved in a car accident, had multiple injuries, multiple surgeries, and unfortunately wound up having a transfemoral amputation. So here, if you were listening to her, she would tell you about how difficult it is to don and doff her socket, how she has to put on multiple liners. Often her skin gets pinched up in her liners. And if you fast forward through this, she also talks about having to wedge her socket on and what it's like to sit uncomfortably at dinner with family and friends. And she's talking about the side of her femur often hits the side of her socket, causing discomfort, pain, and callus formation. She has a cutout to try to alleviate some of those pains. And she also talks about how when she wedges her leg on, sometimes her foot's rotated in or rotated out. So really, it's sometimes patients have extreme difficulty being socket wearing amputees, and they're not restored. They're not living their fullest life. And so that's really where we come in, and the technique of osseointegration. A little bit about the team here. We're from the University of Colorado Limb Restoration Program, multidisciplinary team. And one of the many things that we do is try to take the best possible care of amputees. We have a dedicated amputee program including research, in order to try to give the best, most optimal treatment to these patients, and including innovative cutting edge techniques like osseointegration. So what are the problems with some traditional socket prosthetics? Well, you can see sometimes patients often have burns or complex soft tissue envelopes, especially if they have skin grafts like the top right picture, or redundant soft tissue envelopes cause pistoning of the sockets, wound breakdown, loosening of the limbs to fall off at times, and they have poor proprioception. They have decreased walking confidence. They really can't feel where their limb is in space or the pressure that they're putting through the limb, making it very difficult to walk at times. So this is what a socket prosthetic looks like. And then osseointegration is really a bone anchored prosthesis where we replace the socket with a metal implant that's placed transcutaneously into the intramedullary canal. We're able to use the functional knee unit, ankle and foot of the prosthesis through and connect it to the bone anchored prosthesis via connector. So where does osseointegration come from? It started actually in the 1950s with dental implant technology. So a surgeon named Per Ingvar Brandemark found that we could implant titanium implants into rat bones, and then they would actually osseointegrate. So they developed a two-stage technique, first removing the tooth, which is likened to performing an amputation, opening the skin, placing an implant, covering the skin or gums, in this case, over the implant, waiting a period of time for the integration of the implant to bone, and then coming and opening the skin and attaching a percutaneous or a transcutaneous component called an abutment, and then ultimately the prosthesis or the tooth, just like we do in limbs in osseointegration patients. So early published data using this technique found that there was a 92% survival rate with this screw fixation device named OPRA, with a superficial infection rate of up to 55%, was performed in a two-stage technique. 5-year follow-up still showed a good cumulative fixture or implant survival rate of 92%. And there were some issues with some of the mechanical components, primarily the abutment that was coming through the skin. This has since been rectified. But patients had a profound impact on their life, and their PROs, or patient reported outcomes, were wildly successful and very appreciative of this. In 1999, in Germany, a press fit design was also created. This had its trials and tribulations early on as well, just like the OPRA device. The original implant had this large outrigger and this porous coating, thinking that this would create stability and allow the implant to be well fixed within the femur and the skin to seal. Unfortunately, these had really poor outcomes, lots of problems with infection, and had to be removed. But over time, the design became more lower profile and smooth, much like they are designed today, with much better results. So also through this period of time, learning to manage the soft tissue envelope over time, improve the outcomes, decreasing risk of infection with improving surgical technique. And here you can see in the design A and B, the early designs, there was a higher rate of infection and problems with the implants. But as they got to the more modern design, there was a significant decrease in early and late soft tissue infections, as well as other needs for revision surgery, et cetera. So what does osseointegration really do? So here's a characteristic x-ray on the left of a socket wearing amputee who, when they put weight through their prosthesis, they have unopposed muscle forces, and their femur abducts out to the side and hits the side of the socket, causing pain and difficulty with balance, gait, gait symmetry, and other things. So this long line is where the weight should be going, and the femur is obviously abducted out to the side. When we osseointegrate a transfemoral amputee, we reharness the power of their skeleton, and you can see the alignment now is very similar to their sound side. Other benefits of osseointegration is the phenomenon of osseoperception, where the ability to feel through the prosthesis, how to feel how much pressure they're placing through their prosthetic limb, where it is in space, and amongst other things. Currently, this technique is available for traumatic amputees and tumor patients who have had amputation for tumor. But we hope to offer this for a wider range of patients, including those with diabetes and peripheral vascular disease, as they make up the largest population of amputees in the world. So one thing in order to ensure success with osseointegration, you have to have proper indications. It requires a very thorough assessment of patient goals. It requires a multidisciplinary team-based approach, including all sorts of team members, including osseointegration surgeon, plastic surgeons, peripheral nerve specialists, infectious disease specialists, physical medicine rehabilitation physicians, and the list goes on and on and on. And it's really critical that any program is invested in the long-term care and research in amputees with osseointegration. Our pre-screening evaluation in our program is initiated with a pre-screen questionnaire, where we try to assure patients are eligible for this procedure and understand the patient's goals for osseointegration. Major inclusion criteria is they must be skeletally mature, so reached adulthood in their skeleton. They have to be having difficulty with using their socket prosthesis, and they can be transfemoral, transtibial, or transhumeral, but we are also looking at performing osseointegration in other areas of the skeleton as well. Major exclusion criteria are current smoking or tobacco use, peripheral vascular disease, and comorbidities that may affect healing, such as immunosuppression. During the multidisciplinary evaluation, patients are evaluated for the optimal implant, which may be of the press fit design or the screw fit fixed fixture design. They receive a surgical, medical, and rehab prosthetics and PT evaluation, as well as psychosocial evaluation, and also have the opportunity to speak with OI peers. Our program prides itself on matching patients into cohorts, so they go through their surgeries, as well as physical therapy and rehabilitation with a group which they seem to like very much. What are the two different types of techniques that are performed in order to perform osseointegration in amputees? The first is screw type implants, or OPRA, in which you can see the components here. On the left side here this is the fixture, and then there's components of the implant that are holding the bone graft in place while that bone is incorporating into the implant. And then here on the right, you can see the patient has gone through the stage 2 technique, where the device has been brought through the skin and is ready for attachment of their prosthesis. There's a wide range in the differences in surgery and rehabilitation between the two types of devices that are characteristically used within osseointegration. With the screw type or OPRA system, currently in the United States, it is only FDA approved for use in femurs. There's an age range between 22 to 65. It must be less than 220 pounds, amongst other criteria that are listed here. Dr. Melton will get into a little bit more about the rehabilitation protocol later in the talk. Here's a patient who's a transfemoral amputee. we can see we're going through this is what the preoperative planning looks like as we go through patients, getting CT scan, trying to detect bone quality and canal size in order to preoperative plan for the implant. Stage 1 is rather straightforward, where the implant is buried, the skin is closed, and then we allow 6 months for the bone to incorporate into the implant. However, some institutions are taking that down to 3 months. So here is a patient 6 months post stage 1 osseointegration. One of the benefits is these patients can wear sockets between stage 1 and stage 2. We look for incorporation of the implant during that time. And then here it is after stage 2, where you can see the abutment has been brought through the skin and is then ready to be fitted over time through the rehabilitation protocol until they're able to walk with prosthesis. And Dr. Melton will get into a little bit more of those details later. The other type of technique for osseointegration is utilizing a press fit technique. And here is some examples from around the world of what those devices look like. Press fit can be done in multiple areas throughout the skeleton, femurs, tibias, transhumeral, and can be made into custom devices for very short segments that require different shaped implants in order to accommodate the amputation level. Femurs are typically done in 2 stages with 6 weeks between stage 1 and stage 2, or can be done in single stages where it's all done at once in order to accommodate different soft tissue envelopes. And again, Dr. Melton will speak a little bit more about the rehabilitation protocol. So what that looks like with the press fit technique is we have an existing amputee, the amputation residual limb is opened up, redundant skin, soft tissue, muscle, and bone is resected, the canal is prepared, and then ultimately the implant is press fit into the canal, similar to a total hip replacement. The skin is then closed, and 6 weeks is allowed to pass before a hole is made within the limb called a stoma, and the transcutaneous component is then attached. At that time, they're then able to move on to walking. Here's the example of a very short residual limb on a femur, femoral remnant that actually had to have a bone grafting procedure in order to attain adequate length. And after stage 1, the implant is buried beneath the skin and allowed to incorporate. Typically, patients are in the hospital for 2 to 3 days, and then typically 6 weeks is allowed to pass. And then they come back for the stage 2 procedure, which is an outpatient procedure, and then begin walking with their prosthesis approximately 48 hours later. Here is an example of a transtibial, which is typically done due to soft tissue constraints in a single stage technique with the same 2 to 3 day hospital stay, followed by 6 weeks of osseointegration of the implant, and then rehabilitation thereafter. We have a an extremely large dedicated osseointegration research center and program where a lot of research is going on around osseointegration and how to optimize it for patients so that they can have the best possible outcomes. So some of the data that we have been able to obtain on these patients is we use this active PAL monitor, which is a wearable activity monitor. And here you can see it actually can track whether you're sleeping, lounging around, sitting in a car, walking in the green, or excuse me, standing in green, or walking in red, or exercising in purple. So this is a slide of, you can see, just try to focus on the green and red and what that looks like pre-OI when you're wearing a socket prosthesis. And then you can see a huge increase in the activity levels, standing and walking post osseointegration. Other outcome measures, such as the +M, ABC, and UDAS, all show statistically significant. Here's a socket wearing amputee having a difficult time with gait ambulation, but after osseointegration, these patients have a statistically significant increase in their confidence and use of their prosthesis. Also, we see significant improvement in their balance confidence and walking confidence. And the HUDOS score, or the World Health Organization Disability Assessment Schedule, is basically a measure of how disabled a patient or an amputee feels. And pre-OI to post-OI, essentially after osseointegration, they don't feel like they're an amputee, or they don't feel disabled. It's pretty profound. We also do gait labs, which has shown to have patients' gait symmetry improve quite significantly, which is leading to overall improved joint health, which is pretty exciting. So what happens after surgery? Dr. Melton will talk a little bit more about that. Depends on the type of surgery you have and where it is performed in the body. There are frequent follow-up visits within the first year and lots of collaboration with your local PCP and prosthetist. So here's a couple of quick examples. Patient with terrible pain, unable to walk, unable to go pick up the mail. Here she is after her second stage transfemoral osseointegration. Now she's able to clip on and clip off their prosthesis really easily. And we went from having really difficult time walking to dancing, going to Disneyland with kids, able to horseback ride, and even help husband around the house. Pretty profound. You can see that characteristic correction of the anatomy, making it normal and like the other side. Here's another example of a patient who had a gunshot wound to a tibia and was unfortunately unable to wear a prosthesis due to this complex soft tissue envelope with skin grafts, lots of pain. After osseointegration, has full range of motion of the knee. You can see some nice balanced x-rays, able to clip on and clip off their prosthesis. And if she has pants on, you wouldn't even know she's an amputee. Pretty profound. We went from skin breakdown, pain, constant pain, unable to lose weight, to hiking over 3 miles, biking, swimming, scuba diving, and off antidepressants. Here's one of our cohorts. Here's one of our patients. Now he's able to golf. He was not able to do this in a socket prosthesis. I cannot guarantee that I will improve your handicap with this procedure. And here's another one of our patients who was unable to do the recreational activities like indoor rock climbing, but now after osseointegration, is able to do that. I'm going to turn it over to my partner, Dr. Danielle Melton, to take it from here.
Hi, thanks everyone for joining. I just wanted to say thanks to everyone involved, the Limb Preservation Foundation. Thanks Maria and Molly for introducing us, and thanks Dr. Stoneback. I looked at the list of people that were going to attend today, and I recognize many of the names on the list. Some of you may be surprised to know that I am now in Colorado. Technically, right now, I'm actually in Texas, but I am in the process of starting in, well, actually I started at the University of Colorado, but doing some things remotely. Super excited to be here with all of you tonight. I know we're going to have a lot of time at the end for questions. I just make a kind of housekeeping. If you do have questions, please feel free to put them in the chat room. And Molly and Maria will be monitoring those, and then we'll try to open it up at the end for a panel discussion. So I'm gonna go ahead and so I've been now with the University of Colorado for all of 3 weeks. But I do want to just kind of start here and talk a little bit about how I got involved with osseointegration. You know, I have been doing this, and I'm a physical medicine and rehabilitation doctor. I have had an amputee clinic for close to 20 years now. I've been in Houston. And, you know, it's interesting because I used to present at conferences and talks like this. And if I ever mentioned osseointegration, it was, at least in the beginning of my career, it was really kind of to talk about, you know, this is something that's coming in the future. This is, you know, we have to work out a lot of details before it's ever going to get there. to now fast forward to really now it is here and it is available. In 2014, I think is about when I started to get really involved with osseointegration. And it was because many of my patients traveled to Australia to have it done because it wasn't available in the United States at the time. And then made it back into my clinic and had to figure out what to do with them. And so I started learning more about it, started getting more involved with different implant companies, was really trying to be a proponent to work with the different groups to make sure that it is accessible. Worked with a lot of them on the FDA process and have been involved in that front. When I was in Texas, we got authorization for our first patient in 2019. Of course, if you remember, the couple of months later, the world turned upside down. And so, but the good news with it, what I'm talking about in the pandemic, but since then, I've been involved directly with 9 patients, 2 of which were bilateral, who have had the OPRA implant. And as Dr. Stoneback mentioned, it's the FDA approved femoral implant. I know there's several people in the webinar from that group, and so welcome. The other thing I want to just mention here is that we're a little bit different hat as well, and I'm the Paradigm Medical Director. The reason that's important, for those of you who don't know, I'm a consultant for Paradigm, and I worked with their overall medical director to write a position paper on osseointegration. And I'll talk about that in just a minute. And I think that it's really important for all of us in where we're going with this. I am a big proponent of the team approach. And I think that, that's one of the reasons that I've been working with Dr. Stoneback, because I know that he thinks the same way that I do. If you go back though, Jason, to the position paper, I just want to make one comment on the position paper. Our position paper, which was written in 2019, one of the big things that came out of the position paper is that, or basically we looked at all the data, and as a group, workers' comp has been a little reluctant to say, let's move forward with this without more evidence-based medicine, more research. And so I think in the last few years, we're getting there, but that's what I've been so excited about when I started to talk with Jason about what they're doing here in Colorado. And this isn't intended to be a sales pitch for this group, but I am very impressed with what they've done so far. You can go to the next slide. And that is that they've spent 2 years, even before they started doing their first case, collecting data and assembling a team of people to address osseointegration and all the complications or all the issues that go along with that. And that is really, I think, key. And I've been really impressed with how much data has been collected. PROMs, which are patient-reported outcomes, as well as functional outcomes, which are objective measures that they can collect in the gait lab. And you saw a couple of videos previously to that. And so I think that really is key to how we are going to continue to push the field forward. And so I know there's different people on this webinar. There's probably different people that have different questions about where this field is going. And I think I'm really super excited to see how many people have tuned in, because I think it is really going to take that effort. Next slide. Dr. Stoneback's talked about the different indications. Right now, I think there are certainly some issues when it comes to socket wearing and prosthetic devices. There's a significant indication in femur, humerus, and tibia. Talked about difficulties with socket fit and prosthetic control. And then I think that, making sure that we have the right criteria to recommend this or to for patients to have access. And so I've just listed them here, but we really do want to be clear about what is an appropriate candidate for osseointegration. Next slide. So, I think if you've tuned in, you probably know a little bit about osseointegration. You probably heard all the potential benefits. I have listed some here. Dr. Stoneback certainly talked about a lot of these. I think one of the key things is that it allows direct prosthetic control to be more stable and to be fixated into the bone. And so direct skeletal attachment. Certainly improved range of motion, particularly at the hip, because there's no socket brim. And I think certainly the increased functional capacity that's been demonstrated in many of the articles that have been published about osseointegration, improved walking speed, sitting comfort, very quick donning and doffing, the ability to, or not to have as many skin issues. Now, there may be some separate issues that osseointegration candidates have to deal with, but it's not related to the socket. Improved on falls and
Danielle, hang on
Yep.
1 second. It sounds like there's a flip or something. They're asking me to reshare this. So let me stop. Are we okay now?
Can you go back one slide? If any of you know me, you know that I'm having a really difficult time not controlling my own slide deck. It's a control issue. But Jason, you're doing a great job. Thank you. And reduced energy costs, and I think overall improved quality of life. These pictures, I think, are pretty impressive when you start talking about the ability to sit regularly in a chair, having that kind of range of motion at the knee, and just really how impactful it's been for many of my patients. The two in the top left were the very first two of my patients that traveled to Sydney to have it done. And it's just really impressive and profound on what they report on this. I think we'll go ahead and go forward. Okay. So one of the things that people talk a lot about when it comes to osseointegration is having a normal gait pattern. And so you can see that here. Dr. Stoneback, I don't know if the next one, there we go. Great. So he does this little runway walk. I love that one. And so the other thing that people talk a lot about in the term that's kind of morphed into us talking about it is osseoperception. And that is the ability to feel and differentiate different surfaces. And I think that's really important, particularly when it comes to confidence of walking. Patients who've had osseointegration report that they can actually feel gravel under their feet. They can, and so from a fall risk standpoint, a safety standpoint, that's pretty significant and pretty impressive. Next slide. All right. This is one of the most impressive parts, I think, about osseointegration, and that is the ability to don your prosthesis. The gentleman on the left is a very solid young guy, been a socket user for many years. He's actually very proficient in putting on his socket, but you can see just kind of going through the iterations of wearing a socket, he rolls on his liner. He has to get it just right. In a second, he will put on, go through all the iterations that he has to go through typically to put on his prosthesis. And then we'll start the other one next to it, which is a lady who's had osseointegration. And I think this is pretty impressive when you talk about taking it on and off and just popping it on. She can take it on and off just quicker than the gentleman who started, seconds before, almost minutes before, and then she's done. So if you talk about how many times you have to take on and off your socket a day to check your skin, That to me is a huge quality of life issue for patients. And then you talk about the ability to get up and down off the floor and the range of motion of your knee and how just improved functionally people can be with osseointegration. It's impressive. So talk a little bit about, running. This guy clearly is a great user, young, healthy guy. The next one, by the way, he's putting his heels together to extend his knees. I had a question one time about what that demonstrates, but I think what it does show is that he's a bilateral above knee, sitting in a chair comfortably and with a pretty significant range of motion. Of course, the next video shows guy swimming with flippers on. And so I will make a quick comment in case it doesn't come up at the end. There are different, if you've had osseointegration, you don't want to go into public swimming pools, but people say that, or I think groups that do osseointegration will tell you that it's probably okay to do a clear ocean. Of course, I'm close to the Gulf of Mexico. I'm not so sure Galveston or anywhere along there is something I would recommend people go into just from an infection standpoint. But I do think that that's another ability to get back to doing things that people want to do. Next slide. And that is what people tell me. Patients that have had osseointegration, what they will say is it's getting back to doing the things that they want to do. It's the ability to kayak in a clean environment. It's the ability to hold their child's hand and look down and have the confidence to do it as they're walking across the street. It's the ability to hike and return to that without difficulty of having to deal with a socket, and having the osseoperception to be on unlevel terrain and to be able to handle that while they're walking. And that's significant, and it is game changing. I will also say that even if patients have had complications, they'll say that they would have osseointegration in a heartbeat again if they were asked to do so. Next slide. Great. So there are some considerations when we start talking about osseointegration. Dr. Stoneback hit on a couple of them. There may be some disadvantages when it comes to the overall picture. A lot of times it requires a longer rehab or restarting rehab if you've been a socket user for a long time. Technically, you're not supposed to have any high impact activities, no swimming in public facilities, as I mentioned. Daily stoma care it requires. And some people don't like the aesthetics of what an abutment in a stoma looks like. There are potential concerns. I used to have a slide like this and I would talk about contraindications. I think all of that is changing as we know more and more about it. The reason it's changing is because we're starting to look at the data behind this. I think that's from a safety standpoint is really important. Infection is a significant concern when it comes to osseointegration. So you want to have the right patient selection. But having said that, some of these things that used to be complete contraindications, now they might be relative contraindications, or as we get more data from facilities and institutions like this, I think we'll learn more about who really is a safe candidate for osseointegration. I do want to, if you look at the graph here, I think it's fine in the green section to do walking, biking, camping, dancing, fishing, those sorts of things, hiking or moderate activity. The ones in red, I think just intuitively, you don't want to have high impact activity or perform high impact activity. I like to show this though, because as many of you who take care of patients with amputees on this webinar, you know that patients don't always follow our rules and advice. A picture on the right, there was a gentleman who did apparently go and skydive after he had osseointegration. So those are the things that we need to figure out as we go forward. But certainly we want to protect people maybe from themselves, but we really want to make sure that that we do this in a safe manner. Next slide. So what makes an osseointegration program successful? I think we, at least most people here tonight, probably see the value in having a team approach, an interdisciplinary approach. And it's really very important that we coordinate not only locally where they're having, so basically at an institution that does osseointegration, but then also coordinating that care back home if people have traveled to have it done. And I think that's crucial for any successful program. I think then there is a video there. Looks like there's some difficulty and delayed in having that go, but this is a gentleman who's at the gait lab at the UC Health, and he's and this is also where they're performing all of their patient-reported outcomes and functional outcomes. And I think that the data behind here is pretty impressive, and it's going to allow us to really differentiate some of the things that we've already talked about, who makes a good candidate, et cetera. It is important that we understand the principles behind rehab. I think it's, we talk about keeping the pain low, and when we advance the rehab protocol, oftentimes it's based on pain numbers. We want to make sure that we have safe biomechanics, that we don't get rid of assisted devices too soon, and that that we eventually progress to unassisted walking, but it's based on function rather than a time frame. Next slide. So now I want to talk a little bit about the difference between OPRA and press-fit. So screw fixation, and I say OPRA because that's the one implant that is based on that procedure and type of procedure. And so we'll talk, I'm going to not get into the details behind this particular slide, but I want to talk in general about how this is progressing, because I think it is an evolving protocol. Next slide. So this is an overview of weeks going through the rehab process. It's a little probably difficult to read the small detail on the left-hand side, but basically it is very specific on what the physical therapists are working with for the patients or with the patient when they have osseointegration, and it's very detailed on how that's progressed. And we'll go to the next slide. So this is a lady who's had a osseointegration with the OPRA device, and you can see she has 2 assisted devices, and really trying to make sure that she walks safely as she's going through this process. This is also the rehab protocol for post-op management that we follow, that we followed in Houston, and that the University of Colorado here is following as well. We'll go forward to the next slide. But that protocol is evolving. I think one of the differences between the different implants is the time frame between stage 1 and stage 2. I think initially when Dr. Brandemark created this protocol, it was a hard 6 months. I think after working with Walter Reed and going through many, I guess the data behind this, they've decided to shorten the process to 3 months. And so in Houston, we followed that to 3 months protocol for in between stage 1 and stage 2. And then really kind of advancing the protocol going forward to post-op stage 2, 6 weeks after that, really starting to advance gradual weight bearing to the point of ultimately walking with assisted devices, and then hopefully getting to the point where they're without assisted devices. So we'll talk, I'll have some good examples of some of the patients that we've taken care of. Next slide. So these are just the initial loading prosthesis and what that looks like. And again, it starts with a percentage weight, and then advances to full weight bearing. Go ahead, next slide. This was the first patient that had osseointegration in Houston, and you can see he has an assisted device. I want to point out this next one, if you can see it. He has a pretty significant Trendelenburg, which means he's weak and leaning over his prosthetic device. But after he'd gone through the entire rehab process, he's walking significantly better, and without that lean, and that's pretty impressive to see. This is a gentleman who, when I first met him, and I've been taking care of him for about 8 years, he would walk with his hand on his wife's shoulder every time he came into clinic. So this has been life-changing for him. Just really impressive to see. Next. Next one is the second patient we did. And you can see he had a pretty redundant tissue in his residual limb, and that was fixed significantly. There is a physical therapist that's kind of going through kind of gradual, and then advancing him to outside and over different level terrain as well. So that was kind of the progression of his rehab process. We'll go to the next one. This was one of our first bilateral patients, and I think I think we're learning a lot as we're going through this. This gentleman, I've known him for many, many years. He basically sat in a wheelchair for about 6 to 8 years, had his prosthesis in a closet, and now he is advanced to, go to the next slide. One of the things I want to point out, though, here is some of the challenges that certainly that I've learned along the way is how different it is with bilaterals, and these are the kind of things that that we need to understand as we go forward with this. But it is a little bit different animal when we start talking about that, and so that's I think more to come in the future on that. But he's doing great. Next slide. So let's switch gears and talk about PressFit. And again, kind of a similar slide to the previous overview that I showed. This is a two-stage femur process. The rehab, we kind of just show you different things that they start working on. Unresisted cycling, and then advancing to outside multi-level terrain, but you can notice she still has her assisted devices. Going up and down ramps, again with the assisted devices, advancing it to the next one where he's going around different obstacles, and then ultimately being able to walk unassisted. And I think that all of us can agree that, if he had pants on, you may not even know that he was an amputee. Next slide. So this is a lady, you can see the left is before she's had osseointegration. She's walking on a treadmill in a socket. You can see some of the issues that she's having here. Then the next slide is her walking 8 weeks post-op, both assisted devices in both hands. And then 3 months post-op, you can see she's improving that. And then the last one is 1 year. And this is, I think the team can probably talk to this better because she wasn't my patient, but she was, my understanding is she has made a dramatic difference in her overall psychological acceptance and ability and returning back to her overall function. And it's really impressive to see. So next slide. So do want to make just one issue. I talk a little bit about, I'm a big Star Wars fan. My kids are too. There are 9 amputations that occurred in Star Wars. And so a lot of the things that patients come in and talk about in clinic is wanting to restore their limbs. I don't know if they use those terms, but ultimately what they know about prosthetic devices and restoring limbs oftentimes comes from sci-fi movies. And so some of what I do is spend time talking about educating them on really what is available. I think one of the exciting things, Jason, if you can go to the next one. One of the exciting things and where this is going, I think osseointegration has had a profound impact on the future of this field. I think where we're going in the ability to restore and optimize limbs, osseointegration is part of that. I think when you combine it with other options, and you can see here just some of the examples, Jason mentioned that vascular disease is a significant portion of amputees in the world. The other one is digits, particularly in work-related injuries. And so I think we are really on the cusp of something really exciting in our field. This is part of it. And I'll just make a plug for one of the things that we're very excited about is where this is going, particularly in upper limb. We're in the process of hiring somebody to focus on that research-wise. And so I really think it's just really an exciting time to be part of this. You know, and so we may not be there yet, but I do think with things like this and having educational opportunities like this webinar, we are getting one step closer to where we, you know, are able to restore limbs. It's going to happen, you know, as we progress. The way it's going to happen is to work with a team and an interdisciplinary approach. Super excited to be working with this group going forward. And just want to thank you guys very much for being here tonight, taking your time away from your families in the evenings. I know that's tough, and we'll open up for questions at this point.
Thank you very much, Dr. Stoneback and Dr. Melton. That was a wonderful presentation. And I think that you both are truly the pioneers of osseointegration, and that's greatly appreciated. Now we will turn over to the questions. And one of the questions that came up is that who is a good candidate for osseointegration in terms of patients' goals? What are you looking for when you're evaluating them, when you see them in clinic?
Dr. Melton, you want to take that?
Yeah, I'm happy to take it. You know, so one of the things that I really enjoy doing is following patients long-term. And so when I have a patient coming into clinic, you know, of course, we want to start conventional approach, get him into a prosthesis that's going to, you know, get them back to doing hopefully what they want. If those patients then have pretty significant time with their socket fit, I think that's probably one of the biggest indications for it. I think, you know, really talking to them about what the options are. Of course, I'm really kind of a lot of times screening whether or not they would be appropriate based on some of the things that we talked about tonight. So I'll leave it at that. Jason, do you have anything else you want to add?
Yeah, no, I think that osseointegration is perfect for people who want to pursue activities of daily living with greater comfort. Like they want to go out to dinner with their family and friends and feel comfortable. Exercise, like stationary bike, low impact activities, those sorts of things are the patients are going to do the best with this.
Next question. Could you speak more about osseointegration as a primary option during initial trauma or amputation?
Can take that one. So that's a great question. We have found that patients who have worn sockets and have experienced what that's like, wound breakdown, difficulty with socket fit, just the pain and discomfort from it, tend to do exceptionally well with osseointegration. even if they have problems, if they were to develop a complication, et cetera. For instance, our patient population, no matter what has happened, we've had 100% of them say, of those who have worn a socket previously, that they would do it again, 100%. There's nothing else in my practice like that. The converse, there's been certain certain surgeons in the world have sort of advocated that this is a primary method, and I think there's a lot of problems with that. In a trauma situation, typically you may have an unclean soft tissue envelope, so there's increased risk of infection. We're unsure what the soft tissues will survive in a traumatic situation, and also if they're having difficulty, they're now a new amputee, and they always frequently wonder what would it have been like if I just wore a socket. And so I found some of those patients to be the least satisfied with osseointegration that I've come across.
And I'll add, I think there's, in the different hats that I wear in this, I want to make sure that when we move forward with osseointegration, that we do it in a safe manner. I think one of the things that the FDA is really looking at, one of the reasons that we're trying to make sure that we have a very strong patient selection criteria, is that we're looking at this from a safe standpoint. The last thing we want to do is to do osseointegration as a primary, have a lot of complications, and then everything gets put on hold so that people who really need it then won't have access to it. And I think that brings up a really good point for it, doing this in a very ethical and structured and strategic approach is crucial to making sure that this is a viable option for the right candidates.
Maybe one more question, and then I think we need to let Marcy finish up.
Perfect. Thank you so much. Could you please comment, how can people learn a little bit more about osseointegration, particularly in our program? Is there a website or anything for them to look up to get in touch with limb restoration and osseointegration program?
Yeah, actually there is. So we have a website, and it's www.oicolorado.org. And I'm sure Marcy will post that. You can go to that website, learn a little bit more about osseointegration in general. There's some videos and some patient stories, and then our phone number and email, and we're always happy to answer any questions that anyone may have.
Thank you. I'll head it over to Marcy at this point.
All right, well, we want to thank Dr. Stoneback, Dr. Melton, Molly, and Maria. We really appreciate you joining us this evening and sharing a lot of expertise on osseointegration. We want to thank everybody who joined us. We want to let you know that the Limb Preservation Foundation is really here for anyone who has been diagnosed with a limb-threatening condition. We know how frightening those situations are, and that is why we provide financial, emotional, and educational support. We also support research through the Wilkins Endowed Chair at Colorado State University. So we just want to leave you with the fact that it's really great to be involved, to meet others, and we can definitely offer you that. We have many opportunities to volunteer. We have a peer support program. We have a lot of volunteers who get involved with our golf event and our other events, including a symposium. So we really welcome you to reach out to us as well, and help us connect you with others. Lastly, I want to mention that if you happen to be a golfer, we are having an event exactly 2 months from today at the beautiful Arrowhead Golf Course. This event's been around for 23 years. So if you're interested in golfing or actually volunteering, we have huge numbers of volunteers who like to get involved for the day of. So we definitely welcome you to be part of that. Lastly, you should have received a link in the chat for our survey, and you'll also get one by email. We definitely encourage you to complete your survey because I saw that there were about 50 people on this call. So that means your chances are really good of winning that fabulous $100 gift card from Amazon, and who can't use that? So please fill out your surveys. We will draw our name from those surveys. We will announce it in our August newsletter, which is coming right up. And we really want to thank you all. Thank you so much for joining us. We hope you have a lovely evening, and stay tuned for more programs and education to help you. Have a great night.